some research that we've undertaken at the ESRI looking at how Irish healthcare expenditure compares internationally. So first, by way of introduction, we, through the Central Statistics Office in Ireland, we have Irish health accounts, which are compiled according to a system that was developed by the OECD and Eurostat. This is an infographic taken from the system of health accounts on the CSO website. And as you can readily see, this is a very informative and detailed source of information on Irish healthcare expenditure, everything from how it's financed, to how it compares, to the services that it funds. And these kinds of data are compiled across the OECD countries and enable the kind of comparison that you see here. This is a map taken from the latest OECD Health at a Glance publication, which compares health expenditure across countries. So as I mentioned, we recently published a report looking into this area in more detail, a colleague, Aoife Fitzpatrick and I, and that received some coverage. But as I think you'll see when I get into this in more detail, this is a hard topic to summarize. So it's a very welcome opportunity today to get beyond these headlines. Just at the outset, I'd like to thank some important people who assisted this analysis. Of course, my co-author Aoife, colleagues in the ESRI, peer reviewers, the Department of Health, which funds our research programme, which enabled this detailed research, and then officials from the department, from the HSE, who assisted this analysis, and of course the Central Statistics Office, and statistics offices in the UK and the Netherlands, and indeed also the OECD, who were very helpful to us. Briefly, in this sort of summary view of this research, I'm going to talk a little bit about motivation, research questions, our main findings, and then I want to delve more into explaining our findings and reflecting on them, and finally end up with a few thoughts about red herrings. So first of all, to motivation, why compare Irish healthcare expenditure to other countries' expenditure? Well, this area of comparison becomes very important, I think, to how policymakers view national health spending. So for instance, this quotation was attributed to a spokeswoman for the Taoiseach, then Leo Varadkar, a few years ago, as that health spending in Ireland was the 5th highest in the Western world, and it was suggested that there might be not adequate value, that benefits of public health spending weren't being seen by patients. Now, conversely, when Tony Blair was Prime Minister in the UK, a comparison was made of UK health spending as being lower than the average across the EU, and this led to a commitment to increase NHS spending, which actually was largely realised in those subsequent years. When we look at the question of how Ireland's healthcare expenditure compares internationally, subsidiary questions rapidly emerge. So for instance, what measure is best? And we discovered that depends on the question. Can we rely on OECD health data for such comparisons? Well, not entirely, because countries it emerges differ in their accounting methods. Is social expenditure included? Well, yes and no, it depends on the country. And what explains Ireland's healthcare expenditure ranking? Well, there are, as you will see, many rankings, so many factors which explain it. And to say just at the outset, we've talked through this morning about hospital expenditure. But health expenditure is much more than hospital expenditure. So for instance, this pie diagram shows a HSE programme spending, with the hospital programme just making up 34% of programme spending for the HSE. Here's all the other slices of the pie. Large slices for primary and community care, for care of people with disabilities, care of older people. So to some definitions at the outset. The OECD defines healthcare expenditure as current consumption expenditure on healthcare, but then it also defines healthcare-related expenditure, which isn't healthcare expenditure, but includes other categories like, for instance, social long-term care spending. So what's long-term care spending? Here again are some critical OECD definitions. Long-term care is regarded as services for dependent people. But where they receive help with activities of daily living, like getting up in the morning, getting dressed, that should be regarded, the OECD says, as long-term care health spending. But where they receive help with instrumental activities of daily living, like going shopping or with their finances, that should be regarded as long-term care social spending. and not counted in healthcare expenditure. And the OECD's detailed guidance says that such expenditures should be distinguished even within the same institution. But if this cannot be done, then they should be assigned to the dominant category. This is a challenging area of national accounting. And the OECD, most recently in a report authored by Michael Muller, found that countries' approaches differ, even still. And this can significantly affect comparability of healthcare expenditure. So what is social care expenditure? Well, that depends. Broadly speaking, it's non-medical care, like much care of older people or people with disabilities. But across countries, definitions, fundings, and systems differ, and that's a challenge for comparison. So briefly to our methods before I get to our findings. In this presentation, we're comparing expenditures for the pre-enlargement EU 15 countries, the closest to Ireland economically, and in terms of our healthcare systems. We compare for a number of different categories of spending, measures of spending. We do show you a little bit about the results of a case study from Ireland, the UK, and the Netherlands. And this comparison has been done using data for 2017. So, to our main findings. We find that depending on the measure of healthcare expenditure examined, Ireland's ranking differs substantially. So total healthcare expenditure as a share of national income ranks first top in the EU 15. In this comparison, we're using adjusting for the accounting methods of multinationals, which can distort Ireland's measure of national income, and we're using GNI star for Ireland. Now, in contrast to this ranking, when we look at total healthcare expenditure per capita with adjustment for relative prices across the EU, we find Ireland ranks 9th. That's a big difference between first and 9th out of 15 countries. Why? What is being examined with these two measures? Well, one is a measure of expenditure on services, and expenditure is comprised of price multiplied by volume. The other, by stripping out price, is intended as a measure of the volume of services supplied or consumed. Here's those findings shown in bar charts. Just if you're interested in looking at how other countries compare, there's Ireland as a share of national income, Irish spending, and here's Irish spending per capita adjusted for relative prices. Now, below these main findings again, the next level is we can look at publicly financed expenditure and privately financed expenditure. Total expenditure is comprised of both. And there are very differing rankings that emerges for public and private expenditure in Ireland. Irish public healthcare expenditure as a share of national income ranks 5th in the EU 15, but per capita, adjusted for relative prices, it ranks 9th. On the other hand, private healthcare expenditure stays high as comparatively as 2nd in the EU 15 by either metric. I mentioned that there are inconsistencies in how countries account for social care expenditures. In our year of analysis, 10 out of EU 15 countries allocated some social care expenditures to healthcare related expenditure and didn't include it in healthcare expenditure, whereas Ireland allocated no spending to healthcare related expenditure. And this substantially adjusts international comparisons. This bar chart shows public current healthcare expenditure per capita with and without social care expenditure, and with the adjustment for relative prices. The darker blue bar is healthcare expenditure. The light blue bar is social care expenditure. Now you can see if you look to the right of the screen, the Netherlands, there is a substantial difference between healthcare expenditure in the Netherlands and healthcare expenditure plus social care expenditure. You can see to the right of Irish spending for Finland. Healthcare expenditure looks significantly below Ireland, whereas health and social care expenditure is above Irish expenditure. So, to summarize these main findings, in the first column here, you see 4 different measures of healthcare expenditure as a share of national income, as a share of national income combined with social care expenditure, per capita with adjustment for relative prices, and including social care expenditure with adjustment for relative prices. When we look at the ranking for public healthcare expenditure in Ireland compared to the EU 15, we find that it goes from 5th for the top of these measures to 10th for the final one. private healthcare expenditure, very little alteration. Total healthcare expenditure goes from 1st to 9th. When we then add an additional measure, which is Irish healthcare expenditure as a percentage of the EU15 mean, we find that public healthcare expenditure goes from being 13% above the EU15 mean to 4% below. We find that total healthcare expenditure goes from 19% above the EU15 mean to just 2% above. So to look further at how we interpret these findings, let's look at this volume versus price difference. So there's a relatively high measure of Irish healthcare expenditure as a share of national income, but a relatively low volume measure of per capita healthcare expenditure consumed. To make this translation from the expenditure share to volume, the OECD adjusts using something called the actual individual consumption price index. And it emerges that Irish AIC prices are relatively high, and so too are Irish health prices. Now, a health price index might be regarded as a preferable basis on which to make this adjustment, but in fact it transpires that actual individual consumption and health prices are fairly highly correlated across the EU15. So the consumption price indicator is a reasonable proxy for health prices. It also emerges that Irish health prices are high. Irish hospital prices are, with like consumption prices, 4th highest in the EU15. Irish health prices are 2nd highest. This is an index which includes drugs. Why are Irish health prices so high? Well, as Connor's analysis has shown earlier this morning, health prices are chiefly salaries. And as he also discussed, Beaumont's law in economics predicts that prices in low productivity growth sectors will track those in high productivity growth sectors. Average wages are high in Ireland, 2nd highest in the Eurozone in 2017. It emerges then that higher Irish healthcare expenditure as a share of national income, if one accepts Beaumont's law, is in all likelihood driven by the high wage, high price economy in Ireland. Let's look then at this kind of comparison between the price measure and the volume measure for inpatient care, bringing us back to the hospital care discussion earlier. Well, public inpatient expenditure as a share of national income is actually relatively low in Ireland. It ranks 10th of the EU15 countries for 2017. When adjusted for relative prices and expressed per capita, it ranks 12th. And I think it's, as I said when we discussed public and private expenditure, it's important to delve below total expenditure to interpret Irish healthcare expenditure for policy purposes. You can see here that making inferences from total healthcare expenditure for what is happening in inpatient care could be very misleading. This is the kind of low base from which Ireland faced into the pandemic requirements on inpatient care. So to go then to how countries' approaches differ for SHA accounting, System of Health Accounts accounting, I mentioned that we have looked at the Netherlands and the UK in particular. And in summary, when we looked at health and social expenditure in combination across the 3 countries, we found that the Netherlands was assigning 12% of the combined expenditure to social expenditure and not counting it in healthcare expenditure. The UK was assigning 5% and Ireland was assigning none. And to just go into a little bit of detail on these accounting methods, there's much more in our report. Payments to family carers, which in Ireland are paid by the Department of Social Protection, are counted in our system of health accounts as healthcare expenditure. In fact, they account for approximately 4% of total Irish healthcare expenditure. These would be payments to family members for care, for instance, of a young person with an intellectual or physical disability. The Netherlands counts such expenditures as social care expenditure and excludes them from healthcare spending. The UK counts much of spending on home care services, group homes for people with disability and day services for older people as social care expenditure, whereas Ireland counts it all in healthcare expenditure. Looking then specifically at-home care expenditure. It's regarded as axiomatic that Ireland spends too little on community care. For instance, the 2017 Sláinte Care report talked about shifting away from the hospital-centric model and recommended greater investment in primary and social care. But at first sight, if you look at Ireland's system of health accounts, home care expenditure seems to be surprisingly high. In fact, it's 11% of total Irish healthcare expenditure. But detailed analysis, with the assistance in particular of the HSE, revealed for our work that these categories of home care expenditure included mental health, substance abuse facilities, and expenditure in disability residential services. Now, few countries follow this accounting approach. And then, as I've mentioned earlier, Irish healthcare expenditure on informal family carers is included, and that's at over twice the EU15 mean for this category. When it comes to looking at what's conventionally considered home care in health policy discussions, so expenditure on home helps and personal care assistance, it transpires that yes, what's axiomatic is true, that this Irish expenditure per capita is just 44% of the EU15 mean in this area. So we concluded from this detailed analysis that OECD Health Data, while very informative, very valuable, and the work of the CSO very, very helpful to analysis, it nonetheless has to be approached with caution, and that detailed analysis is necessary for like-with-like comparison. The combination of some ambiguity in OECD guidance and Irish data challenges led us to the conclusion that Irish healthcare expenditure is relatively overestimated, and that healthcare-related expenditure which is accounted for in other countries, should be included in comparisons. Now, the CSO, the Department of Health, and the HSE, we know, are working at deriving social care accounting for Ireland, and we hope that our work will augment and assist in this. Survey data, we discovered, could perhaps assist in improving our data sources. So finally, I promised a few words on red herrings. Red herrings are regarded as distractions. When Zweifel, and Myers published a seminal paper on the role of population age in driving healthcare expenditure in 1999, they described it as a red herring. So one of the topics which frequently comes up in making comparisons of Ireland's healthcare expenditure with other countries is that Ireland is a relatively young country, as we've seen in the earlier presentations. And that for that reason, perhaps it should spend less. But it transpires that so-called older countries don't necessarily spend more. Here, for instance, is a comparison of healthcare expenditure and health and social care expenditure per capita across the EU15 countries by population age. And it can be seen that the countries to the right, with the higher population ages, have a great dispersion of healthcare expenditure level. Even although within countries, more tends to be spent on healthcare for older people, and we've seen even within countries from Connor's presentation, this isn't necessarily a simple equation, but this doesn't translate across countries. So what is happening across countries? Maybe health spending is higher in richer countries, evidence for that. And where there is more formal care, this graph, for instance, graphs that healthcare expenditure per capita against the female labour force participation rate. And actually, there's a very strong positive correlation. Countries with lower levels of female labour force participation, and therefore more informal care at home, tend to have lower healthcare spending. But I'm not suggesting that one should understand something as complex as international healthcare expenditure differences by such simple correlations. There is, in fact, a whole literature looking at spending across countries and over time, which finds that we can only understand it by looking at multiple variables, many of which are significant. And even then, when all these variables, many of which I've listed here, are taken into account, within country factors remain important and hard to capture. So I think when policymakers ask, how does our healthcare expenditure compare? What they're really asking is, how much should we spend? And it's a valid question. But in light of this presentation, I think you need to ask, when you're asking this question, what do we mean by expenditure? Do we mean volume? Do we mean price? If the price, do we believe Irish healthcare salaries should be set relative to the average OECD wage? And if volume, What do we believe drives the volume of healthcare consumed? And maybe the question we need to be asking is, how much do we need to spend on healthcare? What volume of services do we need to meet demand or need? And what price can we sustainably pay? And is it possible to have an explicit conversation about volume price trade-offs, about, for instance, the effect of new public sector pay rounds on healthcare expenditure and our ability to deliver healthcare services? And when we debate spending, are we missing other factors that may damage health and drive out spending? So I leave you finally with this final map from the OECD Health at a Glance 2020 publication, which is looking at population coverage for a core set of services across Europe. Generally 99 to 100% coverage, which protects citizens from the financial costs of healthcare. What stands out for the OECD in this map? What stands out is that in Ireland, 58% of the population do not have coverage for primary care. So this is also a valid healthcare expenditure comparison. Thank you very much.